about the man after which this lecture is named. For those of you who have not known Professor Caridi, if there's a word to explain him, it's all heart. Jim was an amazing interventional radiologist who's contributed tremendously to our specialty, but more than that, he was a friend to all and would go above and beyond to anyone, whether you asked his help or even if you did not, and that's who he was, and that's how I have known him over the years. So it is my absolute honor now to introduce to you Dr. Lewandowski. For those in the world of interventional radiology and interventional oncology, it would be hard-pressed for you not to have heard the name. If Y90 is where it is today in liver-directed therapy, from the world of IO, there are only two names that would come to your mind. That is Professor Riyad Salem and Professor Lewandowski. Bob is a professor of radiology, of medicine and surgery at the Feinberg School of Medicine in Northwestern University. He also serves as the director of interventional oncology at Northwestern University. He joined the staff there after completion of his fellowship in VIR, and he specializes, of course, in liver-directed therapy. He has authored or co-authored more than 150 peer-reviewed journals and the application of liver-directed therapy for patients with GI malignancies, and he performs preclinical research at Northwestern Interventional Oncology Lab and Center for Translational Imaging. And in his capacity, he's developing and evaluating novel oncology therapeutics, delivery mechanisms, and delivery mechanisms. Dr. Lewandowski's work has been supported by the NIH, American Cancer Society, the Society of Interventional Radiology, and he's also one of the past presidents of the SIR. So please welcome Dr. Lewandowski for the annual honorary Caridi lecture. Thank you.
All right. Well, thank you for that kind introduction, Raj. Again, congratulations to you. A fabulous meeting. I commend you for what you're doing here. You're bringing a community together, right? We're all oncology specialists, and we're working together through multidisciplinary care. I think when I reflect on this, it's certainly an honor to be here to talk about Jim. You think about all of the accomplishments of people in our specialty or people in medicine. It's a rare person that has honorary lectures named after them, and there's a reason why. And it goes beyond their accomplishments. It goes into, as Raj was pointing out, the type of people that they are. So, this is, an honor to do this, and I'm really excited to do this. And I want to thank Teresa Caridi, who's in the audience with her son, Jude. I think that, Jim has a legacy. His legacy is all of us, and he has a real close legacy here with us today, too. So thank you, Teresa. So Jim, is omnipresent with us, and I know people that knew him very well think about him often, and I think about his role here and the times I've come down to Miami and been at meetings with Jim. And this is a picture of Jim with his grandkids. These are Teresa's children, a couple of her children, Corinne and Jude. Jude, a few years ago, Jude, you've grown quite a bit. Your hair is grown as well, it looks like. But this was 2020, the last time he was here personally at Spectrum. And I think it's just a great photo of Jim and his family. But he's been here in spirit since then, thanks to Raj. And this is 2021 with Dan Z giving the lecture. And some of these are available. You can watch the videos. And Dan's was a great lecture, really talked about Jim. And I think I learned a lot more than I knew about Jim. And I think it's a good watch for those that are interested. Brad Wood, who's here in the audience, gave the lecture in 2022. Elda Tam in 2023, and Kosi Sophocleus last year. So he's, every year we get to talk about him and honor him in that way. When I think about it, and when I thought about what am I going to talk about, or what is there to say that hasn't been said, and Raj really painted a good picture. I think that Jim is the kind of person that drew me to this specialty. I think the legacy is he embodies the culture of interventional radiology. I think there's a unique culture, and he really has that at heart. And I think the first thing you think about is how innovative he was, right? CO2 angiography and all the work that he did really around patient safety. He was excellent technically, which we all strive to be. He's hardworking. He was productive. He wrote several papers, book chapters. He was very productive, very well known. He was accomplished. But I think those that knew him, if you met him and if you didn't know him, he was humble. You wouldn't know that he was so accomplished. He was very generous with his time, not just to people he knew, but with his patients. He was very people-centric. He was committed to that human connection. Again, I think that's why we're here honoring him, and that's why there's a named lecture for him. He was very empathetic as a patient. He was one himself. But I think at the end of the day, he was driven to live life to the fullest. And again, I think these are things that are just great examples for us and things that we need to keep in our mind. The other thing is that he really loved interventional radiology. So I'm going to pivot and spend some time talking about our specialty. And I know this is a multidiscipline conference, and I think there are probably some trainees here, but I think it's always good to look at what we're doing and sort of then take a step and look at the future and sort of tie it together with, Jim would be proud of what we're doing, and really he set the tone and stage for what we're doing. So our specialty is relatively new, right? 1963, Charles Dotter first spoke about interventional radiology in Czechoslovakia at a radiology meeting. That really, after about 10 years, spawned a specialty. And it's interesting, it was a Society of Cardiovascular Radiology. So interventional is not even part of our name when it first was structured. 1976, this group went to Puerto Rico and had their first meeting, their first conference for our specialty. 1983, recognizing we're interventional radiology people, the name was changed. It was called SCIVR, and it was SCIVR for a long time, a Society of Cardiovascular and Interventional Radiology for quite some time. Then recognizing the importance, and I'll come back to this, of a specialty having a space to generate their data, publish their results, learn, and grow, JVR was launched in 1990. I think this takes us now to us as a specialty, and I think the bottom of this, the birth of a primary specialty, I think we could be very proud that we are recognized as a primary specialty. Well, that started in the 1990s, where the ACGME gave us recognized our vascular interventional radiology, so it's called VIR fellowships, followed by the ABMS recognizing us as a subspecialty. So we weren't a specialty, we were a subspecialty of radiology here in the United States, 1994. And then the SIR recognizing the importance of clinical care. And this goes back to Jim, his role with patients and lessons we learned from him, and the recognition that if we want to be doctors, we cannot just be technicians. The SIR created a clinical pathway. Really, the eye was becoming a primary specialty. So this started around 2000. 2002, the name was changed, so we went from SCIVR to SIR. And then 2012, the ABMS, American Board of Medical Specialties, recognized us as a primary specialty. We were the 37th primary specialty, so there aren't that many. And it had been over 20 years since another primary specialty had been named. So this was a lot of work. A lot of our leaders, John Kaufman, Jean LaBerge, Vicki Marks, and others spent a lot of their energy doing this for our specialty, and they were commended with some awards from SIR recently. But why did we become a primary specialty? What was it that drove us there? Certainly, we have imaging, we have procedures, but it was a recognition of our role in peri-procedural patient care that ultimately convinced the ABMS, the ABR, et cetera, to give us that primary specialty. Certainly along the way, from 2012, we had to create a curriculum, we had to be recognized, we have to have our own board certification, but ultimately in 2016, we started the match, but 2017, we had our first residency match, really. Instead of having people like me who did radiology residencies and then doing a year of interventional radiology as a fellowship, we are matching students from medical school into our specialty. So we are now taking those patients that are interested in clinical medicine, longitudinal care, but they want to be procedurally oriented. So we're competing with the surgical colleagues, which is a specialty more aligned with what we do. Really, the difference was this right here. If we look at our prior era, if we look in the 1970s, 1980s, maybe even in the 1990s, this is who we were. We lived at the intersection between imaging and procedures. And if those that know Bob Vogelsang, one of my colleagues at Northwestern, he calls this the you pick 'em, we stick 'em game, right? People tell us what to do, we do them. And that's not who we are as a specialty, who we want to be. So this is who we are now, right? When we, again, think about these current IR competencies, certainly radiologists, diagnostic radiologists can live in this arena, imaging and procedures. Our surgical colleagues, patient care and procedures. But as interventional radiologists, we really bridge all three. And again, this is the uniqueness of our specialty, and this is what has brought us to a primary specialty. And this is being recognized. This was a paper published last year, a collaboration between the ACR, American College of Radiology, and the SIR, but looking at the value of clinical medicine for us as our specialty. And what this shows, and it's a busy slide, But the more interventional radiology or image-guided therapies that people like us do, as opposed to diagnostic radiology, as we all know there are competing interests in a lot of radiology groups across the world, but the more interventional radiology we do, the more the complexity of the cases that we do. The more complex cases we do, the more important clinic is, more important E&M is in our value longitudinally for these patients. And I think that those, it's an interesting discussion. I'm not going to, because I don't want to know. I think how many people in the room that are interventional radiologists that have a clinic, but it's something that's growing and growing. And I think many of these clinics started as what one would call a consent clinic. Everybody that comes to your clinic is going to get that procedure. You're just telling them, hey, this is what I'm doing for you. We have to move beyond that, right? We have to manage these patients longitudinally. We have to pick patients. We need to see these patients. We choose who's good for these procedures and therapies and maybe help triage to other therapies or make these decisions. So I think this is a very important concept and transition for our specialty. Well, how are we doing? Our first match started in 2017, but the first true match was in 2018. And I'm pleased to say we were the most competitive specialty in medicine in that 2018 match. There's been sustained interest from medical students. This takes us from 2017 to 2022. And then most recently in 2025, I think there's some weird things happened in the 2020-21 era. I think people recognize that. But if we look at 2025 match, record number of applicants, almost 500 people applying for 200 positions. I'll point out that 207 matches for 210 positions. That's really good. Almost every position matched through the match. And we have record numbers of people applying for that. So as maybe some trainees in the audience, good luck. I know the 2026 match is in process. But again, record year for us in 2025. And I really want to point out this last bullet that we had more than double the number of matched IR/DR residents than vascular surgeons, right? So we are a popular specialty, and I think we are building a workforce of people that are clinically oriented, clinically minded, and want to take care of patients. With that, there's an onus on us to provide mentorship, right? It's very important for those in the room that are mentors now. It's very important for those that are mentees to become mentors. We have to build these people that are training in our specialty. I couldn't find a lot of, this is a little bit of a difficult picture, and I don't know if people, that's Jim, and I don't know if people recognize the other person. I'll point out this surprising, I think one of the most surprising, or maybe the most surprising thing to me, that Jim won 12 Distinguished Teaching Awards. I mean, that's unheard of. For those that teach day in and day out, that's very difficult to do. And this particular individual is here with us, and I think was talking about the predator technique in the preceding session. Bo Toskich, one of his mentees that he was really proud of. The first time I met Jim, I had gotten on a bus at the ABR exam, and I hadn't met him yet, and he just came right up to me and said, you guys have to hire this guy. And I'm like, who is this guy? It's one of his trainees. And he said, he needs to be somewhere to grow and build. He was selfless, right? And he wanted the best for our specialty and the best for his mentees. I think he'd be very proud of Bo. Bo's done a lot for our specialty, and I think this is just one example. I know he's had a lot of mentees here with him. So what's next? Where do we go from here? And I think the writing is on the wall. The writing is in our journals. It's subspecialization, right? It's a very natural conduit for us. We're a primary specialty. Bill Rilling here in the audience recently gave a daughter lecture at SIR. It was called the Embrace the Embarrassment of Riches. There is a link to it. You can watch his talk as well. These are sometimes fun to go back and watch. But I think the slide that I borrowed from Bill from that lecture is this. He talked about, as a primary specialty, the need to subspecialize, but he took it a step further, right? It's not subspecialization, it's subspecialization, right? You're not just an interventional oncologist, but you're treating patients in the liver. And I would even argue that it's gotten even more. We have to be even better than that. I don't know how many subs you want to put in front of specialization, but you take somebody like me in my career, right? I'm an interventional radiologist, spend almost all of my time in interventional oncology, and I spend almost all of that time in the liver. I spend almost all of that time in HCC. So we have to build these types of people. We have to have the infrastructure for that. There is a blueprint, right? We're thankful, this is now a dozen years ago, but general surgery went through a process like this, right? And it's been very fruitful for their patients and their specialty. And it's starting to happen. This is Memorial Sloan Kettering Interventional Oncology Fellowship. Now, this is not in a silo. I'm talking about oncology. That's what I do. That's what this meeting is about. This is what we're talking about. But there's similar for pediatrics, interventional radiology, PAD, et cetera. So this is happening sort of globally across the different domains of which interventional radiology is practiced. But this comes back to how do we do this? And we need a commitment to a community. We need, again, to work together to build this. And this has been happening organically behind the scenes. SIR in 2002 created a task force, of which interventional oncology was one. WCIO was formed in 2006, and really it was a congress. And this congress first met in Italy, but it was a mechanism to discuss interventional oncology and oncology in general research and how they interplay. It was designed as a multidiscipline organization, again, as a meeting up front. 2008, ECIO, it's coming up here again soon. Cersei hosted this conference for the first time, and that's been a vibrant meeting as well. The SIO, Society of Interventional Oncology, it was developed in 2017. It spawned from the WCIO, but it became a community, right? It's for IO professionals to connect and work together. And really one of the things is to sort of advance interventional oncology as a pillar of cancer therapy. And then finally, the SIR has transitioned the task forces to clinical specialty councils, but again, the idea is to promote domain-specific growth and development, and oncology is one of the prominent ones there. We have to, again, not just a commitment to community, but we have to commit to other things. We have to develop the research. And there are a lot of different ways for us to do this research, and there are funding. And I really want to point out the industry partners, and many are here today, because we're indebted to them. We're grateful to them. This is a symbiotic relationship. And there's device manufacturers, there are imaging companies, there are pharmaceuticals, but them working together and working with us to deliver the data we need to demonstrate the value of what we provide to our patients, it's what we need. We can't do it without them. There's just one example, the Rowan study, it's Bo Toskic study, its enrollment is complete, but this was a collaboration between a device company and a pharmaceutical company, right? 10 years ago, 5 years ago, this probably wouldn't have happened, but now we're having these companies work together to work with us, and I think we're making major advancements by doing that. Funded research, again, this is not beyond us, right? We have the mechanism, we have the skill set to get funding. I have an NIH R01 grant to look at radiation lobectomy, a therapy I think that we've been talking about for different disease states here. I'm doing it in collaboration with the Mayo Clinic, and it's been a very fruitful collaboration, and I'm not the only person, right? So we can develop and deliver the data that we need to provide support for our specialty. And then our societies are helping us as well. The SIR is creating what's called Vertex. It's a clinical data analytic platform. The SIR Foundation has a clinical trials network. The SIO is a clinical trial collaborative. It's not an exhaustive list. But again, I think that the future is bright in our subspecialization attempts. And this commitment is paying off. This was an article from Dan Z in JVIR last year. Approximately 50% of the articles published in JVIR on interventional oncology. I found that to be an astounding characteristic. We need to develop our own data. We talked about JVIR previously. You know, our medical oncologists, our radiation oncologists, our surgical oncologists, they have their own journal. Now we're starting to see that within our own specialty, CVIR oncology, right? So now we're having dedicated journals to this. Why do we do all of this? You know, again, we're supporting ourselves and bringing this through, but we're doing this in collaboration with our multidiscipline team. Many are here today. I know Dr. Laura Kulik, a hepatologist at Northwestern, I work very closely with. We do this because we should do this. And this is now in guidelines. This is the AASLD guidelines for HCC. But patients should be discussed in a multidiscipline care setting. And there are benefits to that. In nearly half of patients, management plans change because of multidiscipline care. And there is significant improvement in overall survival when multidiscipline care is performed for patients with hepatocellular carcinoma. Now, this is my team. It's not an exhaustive list of people, but these are the physicians that we sort of work together to treat these patients. There's a lot of support behind us in this. But we don't just have a tumor board now. We have a tumor clinic. We see patients together. It's a one-stop shop for our patients. Extraordinarily rewarding for our patients and their families, and for us both personally and professionally. And it's making a difference. This is data that we will present at SIR coming up, but we've doubled the number of patients we see in clinic by doing this. And if you look at the bar graph, us interventional radiologists are in orange, but we're equal partners. It's not like one specialty seeing all the patients and nobody else's. We're equal partners in this. And the other thing, again, I think is very important, the red line is unique patient visits, but the blue line is total patient visits. So we're doing this longitudinally. Patients are coming once and being taken care of. We're managing these patients throughout their disease. With that, I think it's been recognized for a while, but with that, we're able to interact with patients. Now, these bar graphs represent the number of patients treated by specialty for HCC at our institution. This is since sort of the modern era systemic therapy. This is starting in 2019, essentially. You can see interventional radiology treats more patients with HCC at our center than any other specialty. Well, that data is married to the Mayo Clinic data, Bo's data that's been accepted to the Journal of Hepatocellular Carcinoma, May of 2020 to 2025. This is enterprise data. Interventional radiology, again, treats more patients than any other specialty. The difference, it almost looks exactly the same, except surgery is a little bit more here because this includes both resection and transplant. This diagram from Bo's paper, there's a Sankey diagram, but what it really demonstrates is that the touch points of all of these specialties continues throughout the disease course, whether first line, second line, third line, right? We work together. We interact with each other. Patients go from one type of therapy to another, and it's very important to make this seamless and make the communication there. Now, I think it's important to point out, again, I've been talking about interventional oncology, and I've been talking about the liver, and I've been talking about HCC, but this is not unique to that. This is the Mass General data. This is Florian Fintelman, published in 2024 for patients with thoracic malignancies, looking at the multimodality treatment between surgery, radiation oncology, and interventional radiology. Really mirrors what we talk about for HCC. So what started as an idea in the 1980s with tumor embolization as, can we become the fourth pillar of oncology? Really the emphasis of SIO in the mid-2000s and now to where we are today. I think we're making that point that we are. And I think that the fruits of that are, and this has been discussed, the recognition of interventional radiology, interventional oncology therapies as part of international guidelines of many different types of cancers, right? This is ESMO, NCCN, BCLC is very specific, but this is not limited to these types of cancers. It's not limited to patients with early disease, advanced disease. It's throughout the disease process we are recognized, not footnotes, but we actually are recognized, and we have this data to support us in many of this. Do we have room to grow? Of course we do, but we're getting there. So to sum some of this up, this is a future quote of Rob Lookstein, the current president of SIR, and you know, his really clear in his thoughts that the future of interventional radiology is going to be more specialized and more clinically integrated. Exactly what we've been talking about. And he points out maybe more accountable for our outcomes than ever before. And maybe that bothers some people as we sort of at times are a jack of all trades. But you know, his point is that this evolution will not dilute who we are. It actually completes who we are becoming. Now, there are challenges, and this is a really interesting story. Is you know, I'm at a center where we really have that subspecialization. I think I've accomplished a few things in the interventional oncology space. And as recently I was doing a radioembolization, and I come out of the room to do a cone beam CT, the gentleman on the left is standing there and says, "Hey, I need you to go upstairs and put in a suprapubic catheter for me." And I said, and I'm like, "Now?" He's like, "Yeah, right now." And I said, "Well, I'm in the middle of this procedure." He's like, I don't care. And I said, "Well, I mean, can you do it? You're a urologist." And he said, "Well, you guys are the drain guys, right? At my own institution, right? So I get it. You know, we have room to grow. There are challenges, and we have to keep heading these face on." But in conclusion, again, certainly my honor, Raj, thank you for inviting me. Teresa and Jude, thank you for being here. The future's bright, and our future and who we are is really in that culture of Jim and people like him. And Jim would tell us, like, let's keep moving forward, right? Despite these challenges, despite being told you're just a drain guy, keep moving forward. I think some of the lessons that I've learned, and some of these are from people that knew Jim really well, and from what I learned of Jim when putting this together, is Jim would tell us to embrace creativity and innovation. I think he'd really tell us to provide mentorship. This was very important. He'd tell us to prioritize our patients. Again, super important to him. And then finally, again, here in this forum at Spectrum with Raj, with what he's built here, he'd tell us to continue to build our community and work together in the care of patients with cancer. Thank you.